Next is the keynote address by our most academically decorated person of the day, Dr. D. Ramamurty, Chairman of Eye Foundation Eye Group of Hospitals. He will speak to us on role of FLACS in refractive cataract surgery. Over to you, sir.
Thank you so much for the kind invitation to be a part of this session. This is a topic given to me, and some of the points have already been eloquently covered by Dr. Minu Mathan. I think today cataract surgery has completely changed. It's not just about vision clarity where we remove the opacity in the eye, but it is also regarding vision restoration. And now it's more concerned with vision enhancement, where we try to give a 70 or 80-year-old the kind of vision he or she never had right through their lifetime. And that's what the expectation is also. And towards this end, I think laser does help us, because laser has already been connoted with perfection. And because of its increase in predictability, reproducibility, safety, the fact that you may be able to do the excellent phacoemulsification, but I find, at least in my hands, if I have a laser platform, if I'm doing 10 cases, in all 10 cases, I can get almost exactly the same results. It's not just the use of the femtosecond laser, but the fact that the most of the surgery, at least under the femtosecond laser, is image guided by high definition spectral domain OCT, further enhances the quality of outcomes with these when you're using this platform. I think all of us are fully aware of the primary uses of this laser. Capsulorhexis, that you can get exactly the right sized shape and position of the capsulorhexis, because of which your effective lens position is accurate. The propensity for posterior capsular opacification is reduced because the good overlap of the rhexis margin onto the optics of the lens. The asphericity is fully functional, and also the rotation of toric or multifocal intraocular lenses is completely avoided. Lens fragmentation, almost in all types of cataract, the amount of energy that you use is reduced by about 50% when you use a laser platform. Incisions, though much talked about, I personally have given that up because I always prefer a near limbal incision. I find that it's a little difficult to do it with the laser. So both with my LensX and with my Catalyst platform, I go ahead and create the incision using the conventional blade. Arcuate incisions, when you're talking about refractive accuracy and small degrees of astigmatism, is essentially a good tool, and I will be dwelling a little bit on that. And as far as the rhexis is concerned, those of us who are using this laser platform are used to this kind of a rhexis when we have once, especially the nucleus is removed, and this is obviously a great way to put in an intraocular lens. So the advantages as far as the rhexis is concerned is better circularity, better capsulotomy and centration on the pupil and intraocular lens, and obviously translating to a better posterior capsular clarity and better overall aesthetic appearance. And when you are at the end of the surgery, when you look at an intraocular lens placed in a capsular bag like this gives you a lot more satisfaction what you see over here. Though finally the post-operative results might be quite matching in these two instances. One of the ways I enjoy with my Catalyst is that the ability to tailor make your capsulotomy. You can either center it on the pupil, you can center it on the limbus, but I center it on the scanned capsule because that's the way to go, because that essentially means that you are extrapolating the dimension of the lens bag and centering the rhexis onto the capsular bag, because the intraocular lens is going to finally rest in the capsular bag, and once you center it on the capsular bag, that seems to be the right way to go. But when you come across a tilted lens, a subluxated lens, etc., then a custom-made capsulorhexis is possible. I think that's one of the greatest advantages of the laser platform when you're using in these difficult situations. When you are talking about a slightly smaller pupil, you can get a maximized pupil, and this video will show that. Essentially, I normally aim at a 5 millimeter rhexis because generally there is a tendency for the rhexis to retract, and because of about 5.3 to 5.5 millimeters, here you can see that it's coming to 4.5 millimeters. So I can pupil maximize it and essentially move the icon so that I am getting the maximum size about 4.9 millimeters. And as we all know, when you have a 4.9 millimeter rexus, then it's doable. As Dr. Minu rightly mentioned, less than 4 millimeters, I don't believe in putting hooks or something and taking the patient back to the laser. Then you just do a phacoemulsification. Anything up to 4 to 4.2 millimeters, you can go ahead and do that. And then with effective phacoemulsification techniques, with which you are all familiar with, that's a toric intraocular lens that has been placed inside the eye. And with a digital overlay platform, you can ensure that even in these cases, you are getting an excellent refractive accuracy. And Dr. Minu did mention about the vagaries of the laser and the fact that the capsule could be slightly weaker, but I think that's a thing of the past. Earlier, we used to have direct applanation onto the corneal surface, because of which there used to be mini distortions on the dismissed endothelium. This used to make aberrant pulses, because of which, not exactly on the capsular rexus margin, but near to that also there used to be postage stamp perforations, and hence it was initially thought that the capsular rexus created with the laser is somewhat weaker than what is created manually. But today, now we have either a contact lens or a fluid interface which is there in between. Most of the femtolaser platforms are gone on to this, which avoids the distortion quite completely. And this was the initial picture that you used to have, and it's essentially this which used to cause the aberrant femtopulses to fall on the capsular back, on the surface of the capsule. But when you have an extremely smooth surface like that, this is sort of gone away. There are studies which have proven that the capsular rexus created by the femtosecond platform is almost twice as strong as the capsular rexus that's created manually. Having said that, most often the results of a study is dictated by whether you have the femtosecond platform with you or not. So suffice it to say that today there is no longer a controversy as to whether the femtosecond platform creates a weak capsular rexus, because we have seen whether during intraocular lens introduction, whether you want to use a capsular hook, iris hooks, difficult situations, these capsules tend to hold up quite well. And laser arcuate keratotomy, I feel that when you want to debulk the amount of astigmatism, this is a great way to go. The fact that it's image guided, you have a very precise length and position as far as the arcuate incisions are concerned. Corneal thickness measurement, so that whether it's 600, mind you here is you are not placing it at the limbus, but you are placing at 8 millimeters or 9 millimeters. So you can measure the corneal thickness there and then titrate the depth to about 80% to 90%. It is also said, though I personally have not tried, depending upon the residual postoperative astigmatism, you can open up the incisions on the slit lamp about a week later, but I always open it up on the table. And essentially, it is well said that there is a loss of flattening effect if there is even just like intraocular lens misalignment, in case you are doing an arcuate keratotomy, and if you are doing a limbal relaxing incision, which I used to do earlier, but I have given up now, if there is a 5-degree misalignment, there is about a 1.5% loss. If there is a 15-degree misalignment, there is a 13.4% loss. Obviously, when you have the whole thing in an image-guided platform, then the chances of misalignment much less, and you get the incisions exactly where it is meant to be at exactly the depth it is meant to be in. And there are several different nomograms that are there. If you're using the conventional Donenfeld or Nickman nomogram, which are essentially meant for the limbal relaxing incisions, and you are moving the incisions at 8 or 9 millimeters, you reduce the arc length by about 33%. That is, if it is saying that you make a 15-degree arc length, you reduce it to 10 degrees. But you also have specific Julian-Stevens nomogram that's meant for intrastromal arcuates. I personally don't use it, but stick on to the Varion holiday nomogram that's incorporated in it, which essentially gives me the exact penetrating laser arcuates that has to be done. And suffice it to say, when you have a 22 degrees paired arcuates at 9 millimeter, this is just a thumb rule, you get a correction of about 1 diopter. But let me tell you, the functioning of these arcuate keratotomy, even if they are created by laser, is just like a radial keratotomy. You are not absolutely sure, depending upon the biomechanics of the particular cornea, the results might be quite variable, and also the initial correction that you get might also disappear over time. So whenever you have a significant astigmatism, it's a good idea to resort to toric intraocular lenses. This is the opening up of the incisions that I make right in the beginning of the surgery. Here it's at the 90 degrees axis, and I'm going to be seated temporarily and going ahead and doing the surgery. But even when astigmatism at the 180 degrees, which is against the rule astigmatism, which we come across most often in our patients, I routinely make this arcuate keratotomies, and after the implantation of a premium, in this case it's a multifocal intraocular lens that has gone in, I go ahead and open these incisions. I find that the position of these incisions, even temporally, is ahead of the temporal clear corneal incision that I have made. So I do get the benefit of these incisions even when the against the rule astigmatism is there, and it helps me to debulk the amount of astigmatism, which is more important when you are doing multifocal intraocular lenses. Up to about 0.75, 1 diopter of astigmatism, especially if it's with the rule, I go ahead and resort to these incisions. This is what you see on the first day post-operative. This is the ASOCT picture, which shows that it's about 80% depth. Nowadays, I titrate it to move to 85 to 90%. Just like the indications for toric intraocular lenses, it also is not just the magnitude of astigmatism, but it is also the axis of the astigmatism. Like in this case, you see that it's 160 degrees, which means it's with the rule astigmatism. In spite of the patient having about 0.81 diopters of cylinder, no arcs is indicated in this case. This is essentially a readout from the Varion. But while in a case of against the rule astigmatism, and as you can see over here, just a 0.51 degrees of astigmatism, you get almost a 22 degrees arcs, paired arcs that are indicated, which corrects about 1 diopter of astigmatism. It is because the against the rule astigmatism in the posterior cornea, which is about 0.5 diopters, is also added on. So essentially, it's not just using the instrument, you also understand how it functions, and preoperatively, you have to analyze it quite significantly. So it is possible to create the laser arcuate keratotomies from 2 to 11 millimeters. I usually do it at 8 millimeters. The arc length is, can be from 10 to 120 degrees, but I don't go beyond 35 to 45 degrees, because once you go beyond that, then I think the healing is compromised. It's usually 80 to 90% depth. I center it on the pupil, and it's usually a 90-degree side cut that's being used. And this is again, I think most of the points I have already said, so I'm not going to repeat them. So as regards the phacoemulsification process itself is concerned, I think Dr. Vinu has already shown excellent videos on the laser. So this is what you see under the, when you have a soft cataract like this, then I don't do any kind of a cube formation, but it's just a sextant that is being created. I do a hydrodissection through the incisions itself. Once I do that, I find that the entire nucleus just opens up. Essentially, it's like creating pizza pies. And this, as you just look at the CDE, it will remain at 0. Of course, it's a soft cataract. Quite often, you can remove this cataract even with simple phacoemulsification using very little power. But the fact that the nucleus has also been pre-chopped in this very precise manner does help. And the fact that you already have a 5.5 millimeter rhexis which can receive the intraocular lens again helps. As you can see, all I have to do after doing the hydrodissection through the central chop, I just have to separate out. There's hardly any division that's needed of the nucleus. And even in these soft cataracts, which sometimes can be a challenge, the removal of the nucleus and the rest of the lens matter can go ahead in an extremely controlled manner. Cortex evacuation is not really a challenge once you slip the aspiration cannula under the rhexis margin. This is again a toric intraocular lens. I think ASM will not go into those details now. And when it comes to a hard brown nuclear cataract like this, then again, I find that my phaco power usage comes down by about 50 to 60%. It's usually a grid pattern of 200 microns each is what I use, where the nucleus is essentially broken down to small fragments of 200 microns, cubes. And then using the fundamental principles of phacoemulsification, where you do a direct chop and subsequently as posterior plane as possible, you go ahead and remove the nucleus. The purpose is not to show phacoemulsifications here, so I'll just go on towards the end of my this video. Here again, I think I'm going to be implanting a premium intraocular lens, and the entire process, let me tell you, phacoemulsification and laser cataract surgery are not competitive technologies, but complementary technologies. Once you have used the laser optimally and use the right phacoemulsification techniques, you very often end up with optimal outcomes. And when it comes to a white cataract, I think one of the major applications of the laser platform is to repeatably produce the capsular rexus of the size that you need. And you can see an intumescent cataract like this. And I'm able to remove the capsular rexus, the capsule which is free floating over there, quite comfortably. And rexus, I think I'll pass this. And when you are coming on to difficult situation, again, it does help quite significantly. I have 15 minutes? Okay. Okay. And as far as the published literature is concerned, there have been a lot of controversy. And there are several studies which have shown both for and against the usage of FLACS. These are some of the initial papers which showed that the usage of phacoemulsification essentially for use of the laser platform essentially enhances results. But one of the studies which created a lot of attention, and rightfully so, was the multicentric studies which was conducted by ESCRS, which showed that the laser has no advantage. But mind you, this was not a randomized control study. There was no strict case control. Multiple centers post-operatively the outcomes were analyzed. The FLAPS groups had a far higher number of patients with previous keratorefractive procedures. Then the FLACS group patients were also much younger. Maybe they are the patients who could afford this. And also, there are several different parameters which we considered extremely important for premium intraocular lenses that were not taken into account. So essentially, when you have a LENSA platform, several different platforms have come up with different advantages. You can create a small nick like this, and this helps you to position your toric intraocular lens in the exact position. And now we have the femto LDB platform. This economics is obviously a concern when you're using the femtosecond laser. The fact that we can use it both for cataract and cornea, it's also mobile, and we can transport it to different centers, enabling us to get the right results does help. This is the kind of results that you often get with when you use the LRCS platform. Essentially, to conclude my talk, do I consider LRCS an advancement? I'm using it for almost a decade. I definitely think so. But does everyone need it now? I don't think so. Is LRCS the platform that all of us have to adapt in the future? I think only the future will tell. Thank you so much for your kind attention.
Thank you, sir. Thank you for the elaborate coverage of femto. I think we'll go ahead with the talks and come to the discussion at the end. So when Dr. Anaka Herur is setting up her presentation, sir, what I wanted to ask, one point is, do you think that there is any reason why a femto rexus margin will be stronger than a tear?
I think that's why I immediately qualified by saying it depends on who is publishing the paper. You know, this particular paper was to some extent industry sponsor. I also don't believe that any reason a femtosecond platform laser should be stronger than a manual rexus. But one thing is for sure, that the initial concerns about the rexus being weaker is gone away with, and nowadays we all consider that irrespective of the way the rexus is created, with both the platforms it functions quite well.